Hey. Thank you. So we will go ahead and begin our hearing. Welcome to the Health and Government Operations Committee. Please do not forward the Zoom link for the hearings. Staff will not allow anyone who was not invited to testify into the hearing. I ask you to encourage people to watch the hearing on YouTube. Bill sponsor witness timing. The bill sponsor or the designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. Please stay in the hearing until the delegates have had an opportunity to ask questions. Next, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you see the timer finish. Members must remain present with your video camera on during the entirety of the hearing. Also, members, please only ask one question of one witness. If you have other questions, you may follow up offline. Please use the raise hand function to that indicate you have a question. Thank you. Okay, so today we're going to begin with House Bill 1375. It's sponsored by Delegate Kelly, and this is sponsor only. It's entitled Health Information Exchanges, Electronic Health Information Sharing and Disclosure. Delegate Kelly has indicated that we have an expert witness that's going to provide the testimony, and that is Mr. David Sharp. Mr. Sharp, you may begin.
Okay, and thank you. Can you confirm the time? I have how many minutes I have, please?
You have 5 minutes because you're our sponsor.
Understood. Thank you. And good afternoon, everyone. It's a pleasure to be here. I appreciate the opportunity to present on HB 1375. I'm here today on behalf of MHCC's Executive Director, Mr. Ben Steffen. The MHCC supports HB 1375 with amendments. This is a consumer-friendly bill as exemplified by the letter of support submitted to the committee by 18 different consumer groups. The bill requires the state-designated health information exchange to establish and maintain a centralized consent management application that contains consumer opt-out choices, which a health information exchange must access and honor prior to responding to a query for an individual's electronic health information. Today, consumers choosing to opt out or opt back into health information exchange need to complete a separate request form for up to 11 different health information exchanges operating in Maryland. This is an onerous task for consumers, and few consumers truly understand the process. The bill will provide a single solution for consumers to securely record and share their data sharing preferences with the health information exchange. Health information exchanges build secure and robust connections to enable the exchange of health data from disparate health information systems. Although consumers recognize the need and benefit of electronically sharing their health information, they want and expect to control who has access to their electronic health information. The establishment of a centralized consent management application will help address concerns consumers often raise about privacy and security of their health information. The consent management application proposed in the bill reflects the work that MHCC and its Health Information Exchange Policy Board undertook a few years ago. The bill also proposes changes to the definition of a health information exchange to conform it with the federal definition, which becomes effective on April 5th of this year. After discussing the changes in the bill with several stakeholders and hearing their concerns, we believe that more time is needed to consider potential changes to the definition and to get broad stakeholder input on it. The MHCC included in its amendments removing the revised definition of a health information exchange and added language that requires it to convene its health information exchange policy board and engage other relevant stakeholders to come up with a revised definition of a health information exchange, and proposed the definition by October 1st of this year to the HGO and Senate Finance Committee. The MHCC thanks Delegate Kelly for sponsoring this bill. It is an important step forward to address issues that are critical to the advancement of health information exchange in Maryland. The MHCC asks for a favorable report on HB 1375 as amended. And I'm happy to take questions from committee members at this time. Madam Chair, this concludes my presentation for this afternoon.
Thank you, Mr. Sharp, for your testimony. And I know Delegate Kelly appreciates you as well. Are there questions from the members? The first one I do see is Delegate Kelly.
Thank you, Madam Chairman, and just really want to thank Mr. Sharp for your presentation. I want to make sure that I have this clear and the committee has this clear. You circulated amendments to all of the members of the committee earlier today, and with those amendments, we're looking from the opposition from the League of Life and Health Insurers. So with those amendments, those stakeholders are comfortable with this bill. Is that correct?
So Delegate Kelly, you broke up a little bit. You froze. I think you're asking if the stakeholders are comfortable with the amendments. Is that correct?
That's correct. Yes.
Yes. Yes. So the answer to that is yes.
Delegate Cullison.
Thank you, Madam Chair. And so, David, I want to just make sure that I understand. So now the bill as amended only applies to the consumer consent form, and that it become uniform in terms of how it interacts with the health information network. Is that correct?
So yes, but let me say it this way. So the bill had two components, and based upon some of the concerns that that was presented to us by the stakeholders, as we spoke to them a bit more about the definition, it was decided that it was best to have more sort of summer recess conversation and come back to you all with the proposed definition in October. What it does contain or include is the consent management application. It is that box in the middle, if you will, that consumers will be able to log into and record their preferences around sharing of their electronic health information. So these information exchanges, roughly 11 of them are operating in Maryland, would all get that information by pinging, if you will, the centralized application or utility. And it won't require consumers to remember to go here, to go there, to go here, to opt out of information sharing. It's a convenience to consumers, and it will facilitate expanded sharing.
Okay, so and this is all electronic, and consumers, it's an opt-in kind of situation, correct?
So it's actually an opt-out. So health information exchange in general is an opt-out, and consumers can opt out by going into most of their electronic health record systems or working with the HIE through this application utility. So if you opt out at the provider site, it would be from provider to provider within that network. But if you opt out through this application, then it's any electronic health information exchange in Maryland that wishes to have access to your information. They first have to find out if you're approving that release. Okay. And that's where the consent to opt out. But consumers who opt out aren't blocked permanently. They can choose to later on opt back in.
Okay. Thank you very much. Thank you, Madam Chair.
You're welcome. Delegate Johnson.
Thank you, Madam Chair. I was wondering, do the amendments address the concerns of the Attorney General's office with pertaining to the expansion of entities that would get the information and the proposed changes in the HIPAA?
So, Delegate, that's a great question. I would say to you, this is some of the work that we plan to do in the summer recess, if you will, to address those kinds of questions. We believe we have covered the questions and concerns in the amendments from from the Attorney General's staff, but we don't know for sure. So more follow-up is needed.
All right, thank you. Thank you, Madam Chair.
You're welcome. Delegate Hill.
Thank you, Madam Chair, and thank you, Mr. Sharp. I'm not, is this a study or this is putting it into place? And are we talking about CRISP or something else? I'm confused.
So the bill has two components, and one is a recommendation on the definition of an HIE. It's not typically what we think of a study, but it's in consultation with stakeholders that we would come back with a recommendation on the definition of what it should look like and for your consideration. The first part on the consent management utility or application actually moves that forward to require the development and implementation of it. Did I answer your question, or am I?
I think so. May I follow up, Madam Chair?
Sure, real briefly.
All right, thank you. So we're talking about, this is my chart. This is doctor to doctor. This is all kinds of health information, but you also mentioned within networks, or it's between networks, and maybe you can follow with me after. I'm really not understanding which health information we're sharing. If someone opts in, does that mean they don't get to say, but I don't want Dr. Hill to see my records, I only want, Dr. Kelly to see my records? I'm not understanding how this works.
So Dr. Hill, think about it this way. When you enter in patient information in your electronic health record system and you're connected to CRISP today, that information is available to a treating provider when they access CRISP. But now you take all the physicians and because CRISP, while it's the state designated health information exchange, there are others that are operating in Maryland. So what it means is that if a patient of yours wishes to not share their information with anyone else but you, they would go into the application and opt out, which means that the other HIEs in the state or the other providers in the state would not have access to their electronic health information through CRISP. But you would still have access to it, of course.
But could they, but they can in and out of various different ones, not I have to be all out or in. You can maybe follow up with me later.
Absolutely. Happy.
Thank you. Appreciate it. Thank you, Madam Chair.
You're welcome. Thank you. Delegate Krebs.
Thank you. And I probably need something offline too, because I didn't realize there were 11 different information exchanges. If I go to a doctor, how do I know if my stuff is in there? And you say it's in there unless you opt out. So once it's in there, how do I know that I can opt out? And how do I I don't just want it out there for the world. I want it out there for maybe my own practitioners. How do we have control over our health information and know that we do?
So the great questions. Let me answer it in a couple different ways. So today, providers typically tell their patients either they have placards in the office or it's in the notice, they include it in the notice of privacy practices, or in the hospital, you get it as part of your admission/discharge paperwork. If a consumer were to visit the CRISP website for a moment, you would see information related to opting in or opting out. The whole notion of this utility in the middle is to give the consumers a way to control opt out, if you will, so they can block information from moving around through the HIEs. But that's really the thinking of it. Did I get to the origin of your question a bit?
No, I've never seen I don't ever remember seeing the ability to opt out or in. at a certain point in time in a practitioner. So I guess I got to just understand that better, and I can do it offline. It seems to me we should have the choice of saying, yes, I want people to know this versus, because you forget, I don't, it's a little bit broader than I had anticipated, but I'll follow up offline.
Yeah, that's great. That's great. Happy to do so. And that's in part what this utility is supposed to do. It's supposed to give consumers a one-stop place to go in order to allow sharing or to block sharing, if you will.
I like what you're trying to do, but I didn't realize there was so broad of access to begin with. But
Yeah, and you're probably, Delegate Krebs, thinking back to 10 years ago when HIEs were just getting started, and there weren't that many of them. In fact, it was CRISP was the first HIE to operate in Maryland, and as opportunity has grown and as the technology is becoming more pervasive, other organizations have implemented these functions and have largely launched them in nationally, not just in Maryland.
Thank you.
Sure.
Okay, thank you. Seeing no further hands up for questions, this concludes the bill hearing for House Bill 1375. The next bill we will hear is House Bill 1344 that is sponsored by Delegate Kipke, which is also sponsor only. Delegate Kipke.
Thank you, Madam Chair. House Bill 1344, which is titled Mental Health Law, Reform of Laws and Delivery Service, essentially codifies and modernizes the terms in which someone can be involuntarily committed for fear that they're a danger to themselves or others. This bill was the 9th recommendation from the Maryland Mental and Behavioral Health Commission, which was chaired by Lieutenant Governor Boyd Rutherford, and it expressly called for a danger standard to be put forward as legislation. The recommendation said, clear statutory definition of harm to self and others through the work of the Youth and Family Subcommittee and from compelling public testimony before the commission from family members of individuals in crisis is crucial for the state to develop a clear and unambiguous standard for determining when individuals in crisis pose a danger to themselves or others. And it goes on and on and on, but I know we've all, especially because we've been on this committee, have heard from parents over the years, especially parents, when they have a child that is out on the streets and whether it's schizophrenia or something else, and their stories are quite troubling. And this bill would perhaps be a solution to them. You'll see testimony submitted in our system from many people with their stories. The purpose of this bill is to address a long-standing problem with mental health civil commitment in Maryland, a problem not with what the law says, but what the law leaves unexplained. When a person with severe mental illness falls into a psychiatric crisis and cannot recognize their own desperate need for hospital care, our law allows for civil commitment, which is sometimes called involuntary hospitalization, so that the person may be stabilized in a controlled medical setting and getting their life back in order. As in all states, one of the key findings required for civil commitment under our law is that the person is currently a danger to themselves or others. The problem that we have here in our state is that we are one of only 5 states in the nation whose civil commitment law offers zero guidance as to what danger to self or others actually means. As you might imagine, interpretations of this critical phase have varied widely among the various professionals who must make these decisions under the law, including police and emergency responders, clinicians, and judges. Too often, the prevailing view is that the person is not dangerous unless and until they are violent, suicidal, or engaging in outrageously hazardous conduct such as walking in traffic. As reflected in many of the tragic stories shared in our testimony that we have received today, the impact of this narrow reading of the law is often disastrous and irreversible. Families are routinely told that their loved ones, despite being severely mentally ill, in a state of psychosis or delusion, and clearly trapped in a downward spiral, cannot be helped. Yet, because they haven't demonstrated a clear danger of causing physical injury to themselves or to others. This bill is not the entire solution to our mental health system's deficiencies in serving people in crisis, but it represents a huge step in the right direction. The goal is to facilitate more timely treatment by clarifying that a person need not be violent, suicidal, or alarmingly reckless to be dangerous enough to warrant intervention. First, it would make clear that an individual is dangerous to their self as a result of their untreated mental illness and not as a result of indigence. They cannot meet their basic survival needs of food, clothing, shelter, health, or safety. Language of this nature is included in all the laws in 45 states that currently have statutory definitions of danger to self and others. Second, it would make clear that a person is a danger to themselves when they are unable to make a rational and informed treatment decision about their untreated mental illness that places them at substantial psychiatric deterioration. One thing that we've learned about the brain is when you don't treat the psychotic episode, when you don't treat the illness that's taking place, it causes damage to the brain, which can even be irreversible. Common sense shows us that we should cover these circumstances with real language in the law for somebody who's refusing care. Nobody thinks that involuntary commitment should be anything other than a last resort. The bill would leave intact the current law's requirement of clear and convincing evidence, but obviously it would put into the law some teeth to allow individuals to know exactly what must be done before an individual is potentially dead or their situation has spiraled out of control. There is no reason to expect this bill to lead to a flood of additional people. And there's plenty of other testimony in the bill packet. I'll just end with one thing. The fiscal note is indicates that there could be a large cost in terms of treatment, but I'll mention it doesn't include the cost savings from reduced incarcerations. And with that, I'll conclude and be glad to answer any questions.
Thank you, Delegate Kipke. At this time, are there any questions from the committee? I see Delegate Hill.
Okay, thank you, Madam Chair. Delegate Kipke, this is a really good bill. I'm glad that you've taken on this challenge. We've been, struggling for a while to make sure people get the care they need without infringing on their autonomy. I just got off the phone with the Treatment Advocacy Center just before the meeting started, and I've been reading some of the opposition. It's the same issues of who decides, and I like the part about if indigence alone is not sufficient, but here's the question. Have you thought about, or would you be open to discussing the possibility of including active or persistent psychosis as one of the qualifiers, since the way the bill seems to work is that if you're aware that you're living on the street and you're good with that, right? But if you're delusional or have hallucinations, you're not. And maybe what we're missing is just being explicit and saying, and that may be one extreme and we can gradually work towards. So that's the question. Would you be open to considering whether we need to actually explicitly say as long as psychotic features either are or aren't present?
Yeah, I'll take note of your suggestion. It certainly seems like it would be helpful to address some of the concerns raised by others. It's certainly what we're trying to, I think your suggestion is very closely aligned with the goal of the bill.
Thank you.
Okay. Vice Chair Peña-Melnick.
Thank you, Delegate Kipke. I have to say, you and I have been here the same number of years, right? And we always see these bills and they never get anywhere because of the advocate. I think this is really good. My question to you is, the standard that you're proposing will be more flexible, correct?
It is more flexible. There's been different attempts over the years that I think maybe cause a lot of discomfort for people. This is mirrored in a lot of ways after legislate laws around the country that are working. And, so it is more flexible, but it still gives some teeth to those moms and dads that see their kids spiraling out of control with whether it's schizophrenia or untreated illness. And it would provide, I think, some teeth to actually getting their children help.
Thank you. Thank you so much.
Thank you.
Seeing no other questions from the committee, This will conclude the bill hearing of HB 1344. Next bill we will have will be House Bill 1349. That bill is entitled Maryland Prenatal and Infant Care Grant Program. It is sponsor only as well, and it's actually my bill, but I have given the time to Dr. I, and you have 5 minutes, Dr. I. I think, Dr. I, you need to unmute. Dr. I, are you there?
I apologize for that. I had to figure it out. Good afternoon, Chairman Pendergrass, Vice Chair Pena-Melnick, and of course, Speaker Pro Tem Sample Hughes. And thank you for inviting me here today. My name is Dr. Blair Eig, and I'm the President and CEO of the Maryland Patient Safety Center. We strongly support House Bill 1349 and the sponsor's proposed amendments that have been adopted and passed in the Senate. Many of you know that the Maryland Patient Safety Center was established by an act of legislature over 16 years ago to support and improve the safety of healthcare for all Marylanders. Our mission, very simply and profoundly, is keeping Maryland healthcare safe. We work collaboratively with hospitals, healthcare providers, patients, families, and communities in this effort. To that end, House Bill 1349, if passed, will promote patient safety in an area of great need for our state, maternal health. The goal of House Bill 1349 is to reinvigorate the financial support for prenatal care originally provided by a grant in legislation from 2018 and 2019. Currently, the grant is overseen by the Maryland Department of Health in consultation with the Maternal and Child Health Bureau. Funding is capped at $100,000 currently and is only available to counties. So far, only Harford County and Allegheny County have received 2-year grants from the fund. House Bill 1349 would increase the funding to $1.1 million in fiscal year 23 and eventually raise it to $3.1 million in fiscal year 25. It would provide the funding directly through grants to maternal health providers to provide care to expectant mothers in disadvantaged communities who otherwise would not have adequate access to needed health care. The maternal mortality rate in Maryland for Black women is almost 4 times as high as for white women, and the maternal morbidity or complication rate is similarly as high. Providing funding for the needed prenatal and maternity care for these women would avoid complications, save lives, and save money, since preventing complications is much less expensive than paying for them. So in summary, the Maryland Patient Safety Center wholeheartedly supports House Bill 1349 with the amendments as presented. I'd be happy to answer any questions.
Thank you, Dr. Eig. Are there any questions from the committee? I see Dr. Delegate Johnson.
Thank you, Madam Chair. I thought I got a promotion. Can you tell me, in the 2 counties that got the grants, are those programs working?
It's for what I know, they're working, but they're not much money, and we haven't seen any changes. I sit on the Maryland Maternal Mortality Review Committee, and the numbers have been pretty steady. In fact, have gone up with the opioid epidemic, probably related to opioids, but we haven't really seen a significant change, and we really want to affect one now. So I'd say I think the counties are trying to do something good. But the problem with having set this up with counties is that they're not the ones providing the care to the expectant mothers. So they have to then go and find the care to be provided. This bill changes that so that the grants can be provided directly to the providers, whether they be hospitals, federally qualified healthcare clinics, or other providers in the maternal sphere.
Thank you. Thank you, Madam Chair.
You're welcome. Okay, I don't see any further hands. Dr. Eig, thank you for your time today as a panelist and sponsor. We will now conclude the hearing for House Bill 1349. The next bill we will hear will be House Bill 1167, sponsored by Delegate Cox, entitled Maryland Non-Discrimination in Healthcare Coverage Act. Delegate Cox. Melissa, is Delegate Cox with us?
Yes, he's here. He just needs to unmute.
Okay, there he is. Thank you. You may begin, Delegate Cox.
Thank you, Madam Speaker Pro Temp and members of this honorable committee. It's an honor to speak with you today regarding the bills before you. I believe I didn't get to hear it because I wasn't in the waiting room able to hear. I think that you have called, Madam Speaker Pro Temp, that you've called 1167. Is that correct? Can you hear me?
Yes, that's right, Delegate Cox.
Have you called HB 1167?
Yes, I'm sorry. I couldn't get to my cursor fast enough. But yes, we're on House Bill 1167, your bill.
Okay, I'm sorry. Thank you very much. And let me get that pulled up if I may just have a moment, because I did not hear the bill called. So if you will give me a moment to do that work. Thank you very much. Madam Speaker Pro Temp and members of the committee, it's an honor to speak with you today about a very important issue that's involving our aged, our elderly, and our disabled communities in Maryland. And it's a great honor that this bipartisan bill in front of you has been supported by the great people down at the State of Maryland Commission on Civil Rights, an office I've done a lot of litigation work in the last 17 years as an attorney, litigating for the disabled or others under the Civil Rights Commission. And one of the things that I want to point out about this bill is that it is something that will focus very clearly on preventing this term called quality adjusted life year. And the issue with quality adjusted life year calculations is that the hospitals, when they're dealing with either a pandemic or another situation, they're tempted to look at an individual and then judge whether or not they receive care based upon their own subjective calculation of their value of that person's life. And that's illegal. It currently isn't defined, though, properly under the law. And as the Commission on Civil Rights has pointed out, this bill will do that. Specifically, the agency may not develop or use dollars per quality adjusted life year measurements. Further, an agency may not use a threshold or a measure as a threshold to make coverage reimbursements, incentive programs, utilization management decisions, and other, whether such decisions are from the agency or from a third party. So this is a somewhat simple bill in that if you look at the way that the whole pandemic issue played out, in many states like Oregon and other states in the nation, the temptation was to deny care to these individuals. And in Maryland, even there was concern that this was taking place. And thankfully, we have a great system and we can make sure that this never happens here, that this bill will spell out the process that's used, that yes, we can have cost-saving processes that we develop, but we may not use any measurement that says that if somebody has epilepsy or somebody has a disfigurement or a disability that puts them somehow at a disadvantage over medical care. All human life is worth, and every single person deserves quality health care. And I think that this bill will do that. It's a bipartisan bill, and I thank you for your time. We have some witnesses. I'd like to give them the opportunity now to move forward and make the case. And I appreciate your favorable vote on this bill. Thank you very much. And I apologize if my voice is a little bit strained.
Okay, well, thank you, Delegate. We will now hear from persons on your panel. The first individual that we'll hear from will be Joseph Collier. You have 2 minutes.
I'd like to thank the committee for giving me this opportunity to testify for the House Bill 1167, that I might provide a voice to others in a similar situation and to show why we uphold one's choice to live. My name is Joseph Collier and I reside in Columbia, Maryland. Because of the global pandemic, 7 months ago, my brother and I took a leave of absence from our university and returned to Maryland to ensure my father's safety. On October 24th, 2020, 2 days before my father was due to be moved out of his long-term care facility, he had gone into cardiac arrest. In the days following the 24th at the hospital, the majority of senior staff claimed that home care was an impossibility for my father and would repeatedly threaten to end his life. I told the staff that we do not do things because they are easy, but that we do them because they are worth doing. When the staff went quiet, this told me that for all the cruelty and guilt that they were willing to place upon my shoulders for ending my father's life, should they have been in my situation, they would have been unable to bear any of it. For if we betray the trust that we place in our loved ones, how does one expect trust to exist elsewhere in the world? It was only through the fear of legal consequence that the hospital began the process of discharging my father into our care. Upon his release, the hospital failed to properly supply and prepare us. Hours after coming home, his oxygen levels became consistently low, and an ambulance took him to another hospital. Again, we fought for his release. Despite everything, my father was brought home again, where he remained until his death on March 3rd, 2021. During this time, we were told by our home care team that the care we were giving him was the best they had ever seen. When one of our citizens is given capital punishment, we feel pity for the loss of life, and we empathize with their fear of dying. It hurts us. If this is how we feel when the guilty die, then what do we feel when our innocent loved ones are put to death? Even when they are sick, they are still our citizens, and they are still our loved ones. Thank you all for your time.
Thank you for your testimony. The next individual we'll hear from is Mr. Wesley Smith. Mr. Smith, you have 2 minutes.
Thank you very much. Good afternoon. My name is Wesley J. Smith. I'm a senior fellow at the Discovery Institute Center on Human Exceptionalism and a consultant to the Patients' Rights Council. I appear today to urge this committee to support HB 1167. Coercion has no place in the practice of medicine. As such, another primary purpose of HB 1167 beyond the quality of life issue is to prevent unilateral forced withdrawals over the objection of patients and or families of wanted life-extending treatment based on doctors' beliefs about the quality of a patient's life or the cost of care. I emphasize wanted. The term feudal care is often used in this regard, but it is a misnomer. In a feudal care imposition, treatment is not withdrawn because it is not working, but because it is. That is, the desired care is keeping the patient alive when doctors think the patient is better off dying. In essence, such impositions constitute ad hoc healthcare rationing. Decisions about when to accept natural death are not medical determinations, but deeply intimate personal value judgments. As such, it is a profound violation of patient autonomy to allow the doctors to decide. It is worth noting that the bill permits doctors to withdraw from patients' care if he or she disagrees with the decision to continue life support. But because the patient will almost surely die if treatment is withdrawn, the bill requires care to continue until responsibility for the patient can be transferred to another physician. This respects the unwilling doctor's personal ethics without allowing his or her values to override those of patient or family. Again, coercion has no place in medicine. HB 1167 promotes comity, which furthers trust and collaboration in life and death decision-making. Thank you very much for the opportunity to appear today.
You're welcome. Thank you. Laura Bogley, you have 2 minutes.
Good evening, Madams Chair, Vice Chair, and Madam Speaker Pro Temp. Honorable members of the committee, my name is Laura Bogley, and I serve as Legislative Director of Maryland Right to Life. On behalf of tens of thousands of Marylanders who are persons with disabilities, persons with chronic health conditions, older and underserved individuals, we support the Non-Discrimination in Healthcare Coverage Act and respectfully ask for your favorable report. We urge the state to ensure that all citizens have equal access to life-saving medical care and treatment, and that care is not denied based on disability, age, race, ethnicity, or other categories prohibited by law. Historically, individuals with disabilities of advanced age or with chronic illness have experienced discrimination in the healthcare system, including the denial of access to life-sustaining care. This discrimination is inconsistent with society's commitment to human dignity and full inclusion of individuals with disabilities throughout our society. It is incumbent upon the state to require that all entities regulated by or doing business with the state provide medical care or coverage, make non-biased treatment decisions regarding the allocation of treatment and life-saving resources based on individualized determinations using current objective medical evidence, not rating systems or generalized assumptions about a person's disability. Maryland has an opportunity to be a national leader on these issues by acting to establish equitable, democratic, and non-discriminatory standards of care before scarcity begins driving medical decisions across the state. The state must adopt a more inclusive and transparent process for developing medical standard of care protocols to ensure that the state's guidance to healthcare personnel and facilities lives up to the state's commitment to protect all of Maryland's residents. For these reasons, we respectfully urge you to bring this bill to a vote and ask for your favorable report. I thank you for your consideration of this important legislation.
Thank you for your testimony. The last witness we have is Olivia Summers.
Ms. Summers is unable to be with us today.
Okay, thank you. Are there any questions from the committee? I don't see any. This will conclude the bill hearing of House Bill 1167. The next bill we will hear is House Bill 846, also sponsored by Delegate Cox. It is the Public Health Abortions Prenatal Diagnosis of Down Syndrome. Delegate Cox, you may begin.
Thank you, Madam Speaker Pro Temp and members of the committee. This bill is, again, a real honor to bring because today, as many of you know, is the World Down Syndrome Day. And this bill will protect Down syndrome babies. Currently, our own tax dollars and Medicaid funds are being used to allow for abortions of Down syndrome babies. And I respectfully ask a favorable report on HB 846, the Prenatal Diagnosis of Down Syndrome, or the Down Syndrome Dignity Act, because all lives should be protected. And today is the perfect day to make that statement. We say all the time how much we care about the downtrodden, and yet we're using tax dollars to do away with some of the most vulnerable among us. And honestly, some of the people that bring us the most joy, if you've ever known someone with Down syndrome, they are always someone who are bringing joy to people's lives. Other states have passed bills such as this one. This has a protection for those with medical emergencies. So no one can say that this would prevent or endanger a woman. This would absolutely not do that. It would be very focused on protecting the Down syndrome babies. And I want to end with this quote that's in my notes from Frank Stevens, an advocate for the Down syndrome community, who spoke before the United States Congress, and he said these words: "I am a man with Down syndrome, and my life is worth living." And, you know, that's a wonderful and powerful message in today's world, where here's someone with a disability saying that his life is worth living. And we should affirm that as well as professionals that are sworn to uphold life values. And that should be done today. I hope you would provide a favorable report on this bill on this World Down Syndrome Day. Thank you very much.
Thank you, Delegate. The first witness for this bill is Laura Bogley.
Good evening again, Madam Speaker Pro Tem, members of the committee. Again, I'm Laura Bogley, and on behalf of Maryland Right to Life and our chapters across the state, I enthusiastically support this bill and ask for your favorable report. The purpose of this bill is to prevent disability discrimination and the use of eugenics through abortion of a child diagnosed with Down syndrome or suspected of having Down syndrome based on genetic screening. This bill would provide necessary, distinct protections for developing human beings at risk for Down syndrome, preventing discrimination based on genetics or disability. Down syndrome is not a disease, and destroying the patient is not curative medicine. Such acts are a modern-day form of eugenics. Abortion is becoming a search and destroy method for eliminating less than perfect people Rather than pursuing medical solutions to some of these difficulties, there is a regular use of genetic testing techniques to promote abortion. Some studies have indicated that between 50 and 90% of children diagnosed with Down syndrome are aborted. There is a high false positive rate in genetic testing, leading parents to abort otherwise healthy babies. Studies suggest that many undergoing prenatal testing do not do so with the intention to abort, but that medical providers are strongly influencing the abortion decision. Pressuring women to abort after a prenatal diagnosis is not reproductive justice. The long-term effects on women of these abortions should not be ignored. Even Planned Parenthood, the nation's largest abortion provider, notes on its website that studies show that, quote, those who choose abortion because of genetic conditions may suffer more serious emotional effects and may have a greater need for counseling than those who elect abortions for socioeconomic or psychological reasons, end quote. With appropriate medical care, children born with Down syndrome can lead healthy, happy lives like my cousin Kelly Kettle. And there are many organizations and resources to help parents of children with special needs. Alternately, there are approximately 2 million couples waiting to adopt, many times regardless of the child's medical issues such as Down syndrome. For these reasons, we strongly support HB 846 and respectfully urge your favorable report. Give consideration for each human life.
Thank you, Ms. Bogley. The next witness we have is Dr. Francis Arlengos, and you have 2 minutes.
Thank you, Madam Speaker Pro Tem, Madam Chair, Madam Vice Chair, for giving me the opportunity to address you. I urge that you review my written testimony. It's relatively short, but so is the time that we all have. I want to urge your support for House Bill 846. Current Maryland law should not make an exception for genetic discrimination. As we sit in this committee hearing 2 days before International Down Syndrome Day, I ask that you do more than raise awareness by wearing a gaudy pair of socks, which is what we do. Make a statement on behalf of those with Down syndrome that we love all people. We carve out an exception in Maryland law, and by doing so, we encourage genetic discrimination. In many European countries, the abortion rate of Down syndrome pregnancies is 90% or higher. In Iceland, it's as high as 94%. In the United States, that figure is lower only because 25% of women decline to have Down syndrome diagnosed. Among pregnancies diagnosed with Down syndrome, the abortion rate is as high as 90% in the United States, even those who expected not to consider abortion prior to the diagnosis. Our experience is that when my wife was about to have a baby at the age of 35, she was encouraged to have genetic testing, even though we'd indicated that it wasn't going to matter. And the point of that was to push us, in theory, to be ready for it. In practice, when our friends have had these diagnoses, they've been pressured by a variety of medical professionals to consider abortion and not undertake the challenges associated with Down syndrome children. But that's outright genetic discrimination. We need to be better than that. We need Maryland to be better than that. We need to truly recognize that when we advocate for those with to abort the unborn with Down syndrome, then we're cheapening the lives of those who are born with it. I thank you and urge you to support HB 846.
Thank you for your testimony. I will ask the committee if you have questions, because that is the last witness for our favorable panel. Delegate Kipke.
Thank you, Madam Chairman. I very much agree with you that folks with Down syndrome are some of the loveliest people. I happen to have a few as friends, and I think they're just the warmest, kindest, most wonderful people, and I'm very lucky to know them. I was just curious, though, in the states that have laws like this, have there been any practical changes that you could let the committee know about? I don't know if Delegate Dan Cox is the right person, or anybody who may have researched this or have any data on this.
Thank you, Delegate Kipke, and I would ask if Ms. Bogley or the doctor would answer the question.
From my perspective, it's been too soon to see any strong trends on this. At the same time, I would note that one of the goals is to get people to recognize, we'll say, the equal rights of Down syndrome children after they're born, and to get society to not treat them as abnormalities, but as fully human like everyone else.
Thank you.
Okay. Are there any other questions from our committee for the favorable panel? Okay, I don't see any at this time. I would like to move the witness. I'm sorry, did you say something, Delegate Cox?
Oh, thank you, Madam Chair. I just wanted to mention that there were other witnesses that because of the time change of the committee, they were not able to be here as previously had signed up to testify. So they did provide video testimony. I don't know that if it's possible to provide that to the committee, but I think we could send that around if that would be something that the committee would entertain.
Sure, you can send it to the committee staff. Okay.
Thank you.
You're welcome. The unfavorable witness today is Joe Spielberger. You have 2 minutes.
Good afternoon, Madam Speaker Pro Tem, Chair Pendergrass, Vice Chair Pena-Melnick, and committee members. For the record, I'm Joe Spielberger. I'm the Public Policy Counsel at the ACLU of Maryland. And on behalf of the ACLU and the organizations that have signed on to our written testimony, we are here in opposition to HB 846. This bill is part of a larger nationwide trend to stigmatize abortion and push access to reproductive health care out of reach. As you know, there's longstanding Supreme Court precedent upheld for decades that recognizes that the 14th Amendment's Due Process Clause provides a fundamental right to privacy that protects a woman's right to choose. And state regulations may not create a substantial obstacle to a woman's ability to exercise that right. Bills like this one are constitutionally problematic because they would block access to abortion for women who are motivated by specific reasons. A little under 2 years ago, the Supreme Court struck down part of an Indiana law that included a similar ban due to prenatal diagnoses, and the 6th and 8th Circuits recently affirmed preliminary injunctions to prevent enforcement of similar laws that have passed in other states. Maryland needs to ensure that women have all the information and resources they need to make the best decisions for themselves and their families. This bill would take away the right to make that decision and substitute the judgment of government instead. There's absolutely no question that there exists widespread discrimination against people with disabilities, but this bill doesn't do anything to address that discrimination or provide them with better access to healthcare, education, housing, and other services and support which would improve their lives. So instead of undermining women's health and reproductive choices, the state should work to advance real efforts to provide better support to people with disabilities while protecting and strengthening the fundamental rights of privacy and bodily autonomy. So we therefore urge an unfavorable report on HB 846. Thank you.
Thank you. Thank you for your testimony. Are there any questions from the committee? I don't see any. This concludes the hearing for House Bill 846. The next bill we have is House Bill 1198, also sponsored by Delegate Cox. It's public health abortions, drug-induced abortions. Delegate Cox, you can begin.
Thank you, Madam Speaker Pro Temp and Madam Chair and Vice Chair, members of the committee. Again, it's an honor, Delegate Cox here for the record, to ask for your favorable support on House Bill 1198. And the important point of this bill is that it's to protect women. Right now in Maryland, unfortunately, there's little protection for women when they're issued abortion-inducing drugs. This bill, if enacted, would provide protections for women who seek these drugs. And specifically, it would provide that an abortion-inducing drug may be prescribed by a qualified physician and would have standards of care. I don't see how anyone could argue that standards of care shouldn't be applied. And it also provides for guidelines within that of informed consent and requires reporting, including a comprehensive annual report to the General Assembly and public information on facilities in which these drugs are dispensed and prescribed, and the healthcare providers that treat women for adverse events related to these drugs. And even if you support abortion, you should support this bill, because what it'll do is it'll provide a much more safe environment for all women, ensuring that adverse events are actually reported, that women aren't given drugs inappropriately and without proper follow-up, and then left to have severe reactions on their own in a hotel room or in their own house, and then to have that covered up and not properly reported to the public. So to protect quality women's health care, I urge you to adopt a favorable report on House Bill 1198. Thanks so much.
Okay, thank you, Delegate. We will now move to your panel. The first witness we have is Katie Glenn. You have 2 minutes.
Thank you. My name is Katie Glenn, and I serve as Government Affairs Counsel for Americans United for Life, a national law and policy nonprofit organization with a specialization in abortion, end-of-life, and bioethics law. I'm happy to be here to support HB 1198, a bill that addresses the unique safety and public health concerns related to drug-induced or chemical abortions. Maryland's can no longer rely on federal rules to protect women and girls, which is why this bill is needed. Because of COVID-19, abortion businesses filed lawsuits to remove the risk evaluation mitigation strategies that have been in place with the FDA for over 20 years on medication abortion, and they filed their lawsuit in Maryland. The United States Supreme Court recently upheld FDA guidelines, but the litigation continues and is now in the hands of the Biden administration. If the abortion industry is successful and they rescind the FDA rules on Mifeprex, states will have legal ambiguity of what they can do. This bill would codify medical best practices to ensure Marylanders get the care that they deserve. It ensures that women see a doctor before obtaining the drug, that doctor is qualified and competent to provide medical care associated with the abortion procedure. The doctor must be able to diagnose contraindications that mean you're not an appropriate candidate for the drug, such as an ectopic pregnancy, gestational age, and be able to administer RhoGAM for women with an Rh negative blood type. None of this can be done virtually, but if the FDA regs are rescinded, there are abortionists who have said that they are willing to hand out these pills without ever seeing a patient in person or even on video. The Mayo Clinic says that medical abortion isn't an option for you if you can't make a follow-up visit. This bill would require that doctors make that follow-up visit so that women get the care they need. I urge you to vote in favor of HB 1198. Thank you.
Thank you, Ms. Glenn, for your testimony. The next witness is Laura Bogley. You're getting to be an expert today at this.
Yes, thank you again for your time, Madam Speaker Pro Tem. I appreciate it. Again, I'm Laura Bogley, and I serve as Legislative Director for Maryland Right to Life. On behalf of our chapters across the state, I strongly support House Bill 1198, and I thank Delegate Cox for introducing this common sense legislation. The widespread distribution of chemical abortion pills underscores the need for the state to have a protocol for the use of abortion pills, including informed consent provisions specific to the efficacy of the pills, complications, and abortion pill reversal procedure, which is really unknown and very critical for women. Strong informed consent requirements, such as those proposed by this bill, manifest both a trust in women and a justified concern for their welfare. The abortion industry's radical do-it-yourself chemical abortion agenda is taking abortion further outside the scope of healthcare and returning women back to the days of back alley style abortions, where women self-administer abortion and hemorrhage without medical supervision or assistance. This is very serious. The state of Maryland continues to put abortion politics before patients. In 2020, Maryland Attorney General Brian Frosh was one of 21 state attorneys general who pressured the Food and Drug Administration to permanently remove those safeguards against the remote prescription of abortion pills. Maryland has been circumventing the safety restrictions on the remote distribution of chemical abortion pills since 2016 by allowing Planned Parenthood to practice teleabortion as part of a research program. And while Governor Larry Hogan ordered the closures of businesses, schools, and churches across the state due to COVID-19, he allowed abortion clinics to continue killing children as essential health care. Some abortion clinics even conducted COVID drive-through assembly lines for do-it-yourself abortion pills. Despite the fact that Planned Parenthood was exempted from closures and reported an increase in the number of abortions they committed in 2020, the Maryland Department of Health awarded them thousands of taxpayer dollars in COVID relief. This assembly has introduced several bills this session to expand teleabortion through remote distribution chains, including pharmacies, school health centers, prisons, and even vending machines, and to expand taxpayer funding for teleabortion through Medicaid program. These policies ultimately demonstrate the state's disregard for the health and safety of women, and the state has a duty to intervene on behalf of women and girls in this state. So we urge your favorable report of this bill. Thank you for your time.
Thank you. The next witness is Pamela Palumbo. I hope I pronounced that correct. Welcome to our committee, and you have 2 minutes.
Thank you. My name is Pamela Palumbo, and I serve as president of the Maryland Coalition of Medical Pregnancy Clinics, which represent 30 clinics across our state, caring for more than 20,000 women a year, including offering abortion pill reversal or APR. Dr. Cliff McLean, our OBGYN medical director, researched and decided this is a valid medical procedure that we should offer women who begin a medical abortion, have second thoughts, and want to attempt to stop it. In 2017, a woman I will refer to as Lily began a medical abortion and that evening had regrets. She and her husband Googled stopping a medical abortion and found us online at www.abortionpillreversal.com. We did the ultrasound and saw a viable pregnancy. Minutes later, Lily began to hemorrhage. We called the ambulance, and when the EMT unit arrived, they told her, "You just started an abortion, you need to let it finish." At the hospital, she was told again, "Go home, just let the abortion finish." But she was adamant that she had seen a viable pregnancy, and the hospital repeated the ultrasound and found the beating heart. Lily came back to our clinic and began immediately to take the progesterone we had available for her and continued to return in the weeks ahead for ultrasounds. Months later, Isabella Joy was born healthy and whole. We've now had 8 successful APR births and 2 more babies due this summer. Had we not been there, this was an unlikely outcome, as the EMT unit and the hospital were unaware of the simple option to administer progesterone, which is commonly and regularly done with threatened miscarriages. Even vasectomies, men are informed that this is a permanent procedure, but in some cases can be reversed. If we are willing to let men know that vasectomies can be reversed, why are we denying women the information that a medical abortion can be reversed? Women deserve full information when they begin a medical abortion, and only with this full information do women truly have the right to choose for themselves. I respectfully request a favorable vote on HB 1198.
Thank you for your testimony. The next favorable witness is Olivia Summers. Ms. Summers, you have 2 minutes.
Thank you, Madam Chair, Speaker Pro Tem, and committee members. I am Olivia Summers, and I serve as Associate Counsel for Public Policy with the American Center for Law and Justice in DC. I'm speaking today on behalf of the ACLJ and nearly 240,000 concerned citizens, including over 2,800 from Maryland, who support the regulation of abortion. You have my full written testimony concerning the ACLJ support for HB 1198. This bill would enhance the common sense regulation of abortion-inducing drugs, ensuring that they are prescribed only by a qualified physician and that the qualifying physician first meets certain requirements. These requirements are consistent with the FDA's regulation of abortion-inducing drugs under its Risk Evaluation and Mitigation Strategy, or REMS program, which has determined that the chemical abortions pose the risk of serious complications. And thus, the FDA regulates the conditions under which the drugs may be dispensed. In January of this year, the Supreme Court rejected attempts to undermine the FDA's REMS protocol for abortion-inducing drugs and instead upheld the program's regulations. In his concurring opinion, Chief Justice Roberts noted that courts owe a significant deference to the politically accountable entities with the background, competence, and expertise to assess public health. And according to the FDA, as of 2018, the chemical abortion pill has taken more than 3.7 million preborn lives, caused 24 maternal deaths, and resulted in nearly 4,200 reported adverse maternal reactions. It is now 2021, and those numbers have certainly increased. HB 1198 seeks to enhance protections for Maryland women and is consistent with Maryland Code Section 20-208, which requires that an abortion must be performed by a licensed physician. Furthermore, it is consistent with the FDA's REMS program on abortion-inducing drugs. And for these reasons, the ACLJ fully supports HB 1198 and respectfully requests a favorable report. Thank you.
Thank you for your testimony. Next witness we have is Stephen Foley.
Stephen's unable to be with us today.
Okay, thank you. That concludes our favorable witnesses. Are there any questions from the committee for our favorable panel? Okay, I don't see any. I will now move to an unfavorable witness, Robin Elliott. Robin, you can begin.
Good afternoon. I'm Robin Elliott. I'm here today on behalf of Planned Parenthood of Maryland in opposition to this bill. Planned Parenthood of Maryland, as well as some of the other organizations that submitted testimony, believe that abortion is healthcare. And as HGO knows, healthcare services are regulated by a very robust set of statutes and regulations in Maryland's code. We believe the bill would essentially eliminate access to medication abortion in many places. It imposes a complex and clinically unjustified web of requirements on the administration of abortion medication, and it imposes a felony to anyone who violates those rules. This would have a chilling effect. The bill would also have a chilling effect on the administration of medication that can be used for abortions, but also for miscarriage management, and could impact the lives of women who are hemorrhaging or experiencing postpartum complications. The bill also requires the distribution of misinformation about abortion and abortion reversal claims, and would require this to be on the Department of Health's website. And finally, the bill would expose personal health information under the Public Information Act, because all adverse reactions would be required to be reported. And the bill specifically says that those could be revealed under a Public Information Act without the individual's name, but with all the identifying clinical information. And for those reasons, we oppose the bill. Thank you.
Thank you, Ms. Elliott. Are there any questions from the committee for Robin Elliott? Okay. There being none, this concludes the hearing for House Bill 1198. Thank you, witnesses, for your time today.
Thank you, Madam Chair.
You're welcome. The next bill we will hear is House Bill 997, sponsored by Delegate Metzger, Equal Protection for Unborn Human Life Act. Delegate Metzger, great to see you today. You have 5 minutes.
Good afternoon, Madam Pro Tem and Madam Chair and Madam Vice Chair, and of course, distinguished members of the Health and Government Operations. For the record, I'm Delegate Rick Metzger, your friend from Legislative District 6 in Baltimore County. Thank you today for this opportunity to speak to you. It's always great to be amongst my friends. The Declaration of Independence states that we hold these truths to be self-evident, that all men are created equal, that they are endowed by their Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. The purpose of this bill today is to grant equal protection for the unborn human life. Any statute, regulation, or rule, order that has the purpose, intent, effect of allowing any abortion in the state infringes on the unborn human's persons of life is a violation of the 14th Amendment to the United States Constitution. The 14th Amendment states that all persons born naturalized in the United States and subject to the jurisdictions are therefore United States and of the state wherein they reside. Ladies, no state shall make or enforce any law which shall abridge the privileges or immunities of the citizens of the United States, nor shall any state deprive any person of life, liberty, or property. without due process of the law, nor deny any person within its jurisdiction to the equal protection of the law. Due process is guaranteed under all of us under the Fifth Amendment. Ladies and gentlemen, today, equal protection is one of the fundamental natural rights. The enactment of the state law protecting the rights to life of all human persons is the constitutional responsibility of the legislative branch, not the judicial branch. I speak to those who cannot speak to themselves or for themselves. Ladies and gentlemen, if I take someone's life, I can be prosecuted for murder or manslaughter. Therefore, anyone with the intent to cause death or serious physical injury by surgical, chemical, or other means to a fetus should be prosecuted under the criminal laws. Any human being, zygote, embryo, or fetus deserves the same equal protection under the law as you and I. If a pregnancy persists as clear and immediate threat to the life of the mother, a medical professional shall use all means to exhaust all medical resources to save the lives of the woman and the embryo or fetus. And the medical professional may not be subject to prosecution under this law if the medical professional provides documentations of his or her efforts. Therefore, ladies and gentlemen, both the mother and the embryo or fetus shall be treated as patients, prohibiting the Maryland Medical Assistance Program from providing certain services to certain women that could cause or attempt the cause of an abortion, and repeal certain provisions of the law relating to the provision of the abortion services. Equal protection is the hallmark of our democracy. I respectfully request a favorable report on House Bill 997. And I thank you today for your time and consideration. And I will yield the rest of my time to Miss Adelaide, Catherine Adelaide, and the parties thereafter. I appreciate your time and love you all.
Thank you, Delegate, for your testimony. The first witness I have, and I'm going to go in the order that's signed up, is Vince McAvoy. Mr. McAvoy.
Mr. McAvoy is not going to be with us today.
Okay, thank you.
He had to leave because of the time change.
Sure, thank you. The next witness is Tom Henry. Is Mr. Henry with us today?
He was.
Yes, I am. Sorry about that. I did not start my video. My apologies.
Okay, welcome.
Okay.
You have 2 minutes.
Thank you, ma'am. Madam Speaker, Pro Tem, Chair, Vice Chair, members of the committee. For the record, my name is Tom Henry. I live in Parkville, Maryland. I thank you for allowing me to testify in favor of House Bill 997, a critical piece of legislation. Since the parents who raised me could not have children, adoption was the path that they chose. I was unaware of this until my parents told us when they thought I was old enough to understand. My brother was adopted as well. But was I upset? No. I carried it as a badge of honor, as my parents would humorously remind me that we chose you, the others had to take you. Back then, we did not have the science that we now have. A heartbeat is now accessible as ultrasound in 6 to 7 weeks and could survive outside the womb at a very early time. Advances to save the life of the mother in extreme cases has also increased greatly. Even without that knowledge 50 years ago, my parents respected the sacredness of life and the desire to raise a family. They would never have foreseen their future son as an all-American runner, a world record holder, 4 grandchildren, and other countless fruits that the seeds of their choices made. I'm also blessed myself with 1 grandchild, a joy I would not experience otherwise. The Hippocratic Oath invokes the Almighty on 2 occasions, committing to purity, holiness, and beneficence. It also states that I will neither prescribe nor administer a lethal dose of medicine to any patient, even if asked, nor counsel any such thing or perform the utmost respect for every human life from fertilization to natural death, and reject abortion that deliberately takes a unique human life. By not enacting this bill, it's a direct violation of the oath that the physician swears upon, and allows said oath to be nothing more than a pro forma ritual with little value on upholding the tradition. Everyone involved in my survival were pro-choice. My blood parents chose life. My adoptive parents chose life. And now I live because they chose life. Without life, there's no family. Family and life are inseparably connected. I thank you for your time today, and I urge your vote in favor of this good piece of legislation. Thank you.
Thank you, Mr. Henry. The next witness we have is Catherine Adelaide, and I know the delegate asked to yield a minute of his time to you. Are you present with us?
I am. Can you hear me? Can you hear me? Hello, I'm
You
here.
can begin.
Okay.
Yes, I hear you. Nice. I hear you.
Okay, is my video working also? I've turned the video on. Can you see me?
Yes.
We hear you and see you.
Okay. All right, thank you. How much time do I have left from the delegate? Will you call that?
A minute and 15 seconds.
Okay. I just would like to continue with some of the law on this subject. Roe v. Wade is not the law of the land because constitutionally courts cannot make law. This is the greatest legal fiction ever sold to the American public, resulting in a Holocaust of 60 million and counting. Article 1 of the US Constitution says Congress shall make the law. This is basic separation of powers law, the legislature, the executive, and the judicial. You are the legislators. You can repeal section 2103 and 2103 on the criminal law that creates the exemption of abortion in the murder statute. You can now create equal protection for all persons, no matter how small. It's time to stop just regulating abortion and time to end abortion. I'm Catherine Adelaide, and I have a law degree from the University of Maryland. Thank you for your time.
Thank you. The next witness we have is Wei Yang, and I hope I said that correctly.
Oh, ma'am, I still have 2 minutes under I'm a witness also. You able to hear me?
I thought you had concluded. Go ahead, I'm sorry.
Oh, I used the delegate's time. I still am signed up as a witness, but I'll be glad to go after Wei so she can have her time, but I should still have 2 more minutes as my witness.
So you just used, are you saying you just used a minute and a half, a minute and 15 seconds?
Yes, I just used up the remainder of the delegate's time, and I still have a witness.
Okay, well then go ahead and use your 2 minutes. I'm sorry, go ahead.
Okay, you want me to go start again? Okay, dear
Yes,
Madam,
ma'am.
and my video is working because I see you, but I
Yes,
don't.
yes, just continue.
Dear Madam Vice Chair.
Everything is working fine.
Okay, great. Dear Madam Vice Chair and committee members, thank you for the opportunity to give testimony, to allow me to give testimony today in support of the bill entitled Equal Protection for the Unborn Human Life Act. In my opinion, there is no social problem for which abortion is the answer. Not poverty, not racism, not sexism, not human trafficking or domestic violence. No, not even rape or incest, which are the only crimes in America where an innocent third party is put to death for the criminal acts of another. Abortion is the ultimate form of domestic violence, not just in the home, but in the home and the cradle of life, the womb where we all began. I am a survivor of domestic violence and have known many victims who were forced to have abortions because of their abuser. I present this bill as a nonpartisan bill, as groups such as Feminists for Life, Democrats for Life, the Pro-Life Alliance of Gays and Lesbians, Secular Pro-Life, which claims 6 million non-religious pro-lifers, and Pro-Black Pro-Life. All groups support the end to legalized abortion under the umbrella of the new and fastest growing human rights movement in history. The human rights movement is an offshoot of the civil rights movement and relies on equal protection under the US and Maryland Constitution. In my own case, I was heavily pressured to have an abortion at 19 by my husband, who was in graduate school, and my doctor. I was only able to make a real choice because abortion was still illegal in Missouri, but legal across the river in Illinois. I hid my pregnancy for 3 months, hoping that I would not be pressured into an abortion because of Roe v. Wade. Because abortion was illegal, I was able to say no to that pressure, and today I have a grown daughter and 3 grandchildren. We often forget that deliberately ending the life of even one child wipes out generations of human beings. It's time to give equal protection for all life to all human beings. For these reasons, please give this a favorable report. Thank you.
You're welcome, and thank you for your testimony. The witness, Wei Young.
Hi, my name is Wei Yan. I'm living in Baltimore County. I was from China and I went to Japan after high school graduation. I got a PhD of pharmaceutical science and came to USA for postdoctoral fellowship. I have a daughter and we pay lots of attention and effort on her education, even from her prenatal status. I always hope to have more children and I don't understand why people allow abortion. I summarize some points as following. First, based on scientific research and the Bible, human beings start from fertilization. What's more, abortion destroys women's health. To protect their human rights, abortion should be illegal. Second, raising children can stimulate economy. However, on the other hand, abortion costs millions of taxpayers' money. Third, children are gifts from God. No matter they are healthy or not, they bring lots of amazing joy to the family and long-term hope to the society. Fourth, more people produce greater strength. More logs make a bigger fire. Many immigrants move outside USA to USA. So to keep consistency of this policy, abortion should not be allowed. If the parents don't have ability to raise a bond, they can fund families for adoption. Fifth, China made a big mistake in birth control by abortion. Now there are more males than females and aging population is increasing, but the birth rate is decreasing. Now they realize that and they promote people to have a second child. Sixth, Japan has the world's oldest population, where more than 1 in 4 people are at least 65 years old. So I'm favorable for this bill and HB 995. Thank you.
Okay, thank you for your testimony. The next witness is Dr. Francis Arlingas.
Thank you, Madam Speaker Pro Tem, Madam Chair, Madam Vice Chair. My name is Frank Arlinghouse. I'm from Ellicott City, Maryland, and I ask you to issue a favorable report on House Bill 997. Abortion supporters often object to any bill that we put forward to help help propose a standard of care on abortion that applies to other medical procedures under the guise that we're just looking for a foot in the door. This is not a foot in the door. This is basically saying we want to recognize the personhood of all human beings, born and unborn. My wife, my 3 daughters, and I all maintain that every human being is inherently of inestimable value from conception to natural death. We believe that because we believe each person is created in the image and likeness of God. But at the same time, we can also approach this from a more secular American view. Our core values include life, liberty, and the pursuit of happiness. Logically, the first among these is life, for without it, none of your rights are meaningful. In our society, throughout our history, we've seen a failure to live up to some of these ideals, a failure to extend these to all people, and that's a source of great pain and shame. This bill is living up to those principles. It says all people, all human beings from conception are fundamentally valuable and worthy of life. I applaud Delegate Metzger for submitting this, and I ask that you issue a favorable report on House Bill 997.
Thank you, Dr. Arlinghouse. I got your last name correct this time. What we will do is have questions from the committee for this favorable panel. Are there any questions at this time? Okay, I don't see any. I will move to witnesses that are favorable with amendments. The first witness is Dawn Nickel. You have 2 minutes.
Thank you, Madam Vice Chair and members of the committee.
Thank you for taking the time to hear my testimony today. My name is Dawn Nickel, and I support HB 997, Equal Protection for the Unborn Human Life Act, with an amendment. Currently, new section 2A-103, paragraph A cites, any person who provides or procures an abortion by any means, whether chemical, surgical, or by any other intentional act, or intentional destroys a living human zygote, embryo, or fetus for any reason is subject to prosecution for murder or manslaughter under Title II of this article. I would like to see the bill amended by adding the words "except for the pregnant woman" after the word "procure" in section 2A-103A section to read any person who provides or procures except for the pregnant woman an abortion by any means. The reason for this amendment is too significant to hold the abortion provider accountable for those who procure an abortion for a woman, such as domestic abusers, pimps, and human traffickers under the criminal law statute. Sorry. It is not necessary to criminalize the pregnant woman or girl. For I once was a girl of 16 with an unplanned pregnancy, and it really wasn't a choice for me. I was pressured to have an abortion, and it was very traumatizing. I didn't understand the consequences of that choice and the lifelong scars it would inflict on me and my family. Sorry, please find it favorable.
Sure. Thank you, Ms. Nickel, for your testimony today. We do appreciate your time. The next witness is Laura Bogley.
Thank you again, Madam Speaker Pro Tem. I promise you this would be the last testimony of the day for me. My name is Laura Bogley, and I'm speaking again on behalf of Maryland Right to Life and our chapters across the state. We respectfully ask for your favorable report on House Bill 997 with the amendments we submitted to the committee. The right to life is inalienable and requires equal protection under the law. Both the Constitution of the United States and the Constitution of the state of Maryland prohibit government from infringing on the natural or God-given right to life and compel government to guarantee equal protection under the law. No legislative, judicial, or executive body of government may lawfully establish a competing or antithetical right to destroy human life through abortion. By the time the 14th Amendment was ratified in 1868, the states widely recognized unborn children as persons. 23 states and 6 territories referred to the fetus as a child in their anti-abortion statutes. 28, including Maryland, labeled abortion as a crime against the person. Even as they fabricated a right to abortion, the Supreme Court in Roe v. Wade acknowledged that abortion is the deliberate destruction of human life. Medical science is clear that a unique human life begins at the moment of fertilization. Killing human beings is a solution to political and social problems such as elite eugenic organizations attempting to decrease the population of unwanted racial groups by locating Planned Parenthood clinics in predominantly Black and Hispanic neighborhoods has no place in a just society. Abortion is now the leading killer of Black Americans, and we are being forced to fund this genocide. While we strongly support the equal protection of the law for preborn human beings, Maryland Right to Life does not support policies to establish criminal penalties for women seeking abortion, and we have submitted amendments to that effect. Legal abortion is about physician immunity, not women's health. As Justice Ruth Bader Ginsburg stated, quote, "Roe isn't really about women's choice, is it? It's about the doctor's freedom to practice. It wasn't woman-centered, it was physician-centered," end quote. On behalf of pro-life citizens across the state, I urge you to uphold your oath of office to serve and protect the Constitution and all people of the state, uphold the equal protection of our laws for all people born and preborn. Thank you.
Thank you. Thank you for your testimony. Next, we'll have Catherine Traskovich. Welcome to our committee. You have 2 minutes. You just need to unmute. Ms. Trakovich.
I'm here. Got me? You hear me now?
Yes, I do.
Dear Madam Chair, members of the committee, my name is Catherine Traskovich, and I appreciate the opportunity to give testimony today. I support House Bill 997, the Equal Protection for the Unborn Human Life Act, with one very important amendment, namely to remove the exception under the criminal law article, new section 2A-103 on page 6, beginning at line 9. Under new 2A-103, the words "except as provided in subsection B of this section" should be deleted. Paragraph A would then read as follows: any person who provides or procures an abortion by any means, whether chemical, surgical, or by any other intentional act, or who intentionally destroys a living human zygote, embryo, or fetus for any reason, is subject to prosecution for murder or manslaughter under Title II of this article. The reason for amending the bill to exclude any exception is because I believe any exceptions are used to murder babies by doctors who think they're helping frightened, desperate, uninformed, trafficked, or abused girls and women. Also, in the case of a pregnancy that presents a clear and immediate or proximate threat to the life of the mother or any person in a life or death situation, medical crisis, a medical professional is already required to exhaust all medical resources to save the life of the mother or the woman or any person, including a preborn baby, under their Hippocratic oath. Particularly in a pregnancy where there is either maternal or fetal distress, we now have the ability to save both the preborn baby with neonatal technology, the mother, and providing both parties with a team of doctors and nurses. The exception in paragraph B just gives doctors a loophole for being prosecuted. Paragraph A is more than sufficient to provide true equal protection for every preborn baby, regardless of who provides or procures an abortion. The focus of this bill is to criminalize any act of abortion so as to provide equal protection for all preborn life. Please give this bill a favorable report. Thank you.
You're welcome. Are there any questions from our committee with regards to the panelists for favorable with amendments? Okay. I don't see any at this time. I will move now to unfavorable. Diana Phillip, you may begin and you have 2 minutes.
Good evening. My name is Diana Phillip. I'm Executive Director for NARAL Pro-Choice Maryland in opposition of House Bill 997. Pleasure to see you, Speaker Pro Tem, and members of Health Government Operations. We're an organization that strives to help every individual choose if, when, and how they form their families, and when they parent, to do so in safety, in dignity, and good health. We honor pregnancy in all its complexity, and we work towards people with having a positive maternal health outcome and fighting against reproductive coercion. And that includes making sure that no person is forced to carry a pregnancy to term against her will. We are opposed to this legislation because, as you've heard, it calls for the state to recognize a fertilized egg as a person. And in granting personhood, it destroys an individual right to bodily autonomy and pregnancy decision-making. You've also heard the call for prosecution of abortion care providers and patients for murder or manslaughter. Not only would this ban abortion in our state, but it would also lead to arrest, investigation, prosecution of anybody with a pregnancy loss. And it also interferes with those accessing reproductive technology in order to become pregnant so they can realize their goals for family formation. 30 years ago, the Maryland General Assembly passed legislation legalizing abortion, and it was affirmed by ballot referendum the year later by 62% of the voters, and we believe it would stand today. So we urge an unfavorable report on House Bill 997. Thank you.
Thank you, Ms. Phillip. Are there any questions from the committee for Ms. Phillip? Okay, I don't see any. That concludes the hearing for House Bill 997. Thank you, Delegate Metzger, for your bill for today. The next bill we will hear will be House Bill 1112, Delegate Weigel, entitled Public Health, Maternal and Child Mortality Review and Perinatal Hospice Services. Delegate Weigel, you may begin and you have 5 minutes.
Thank you. Can you hear me?
Yes, I can.
Thank you, Madam Speaker Pro Tem and honorable members of the Health and Government Operations Committee. I'm happy to introduce House Bill 1112 for perinatal hospice services. House Bill 1112 directs the Maryland Department of Health to develop a list of perinatal hospice programs available in the state and nationally that is organized geographically and publish on its website an information sheet on perinatal hospice programs, as well as a list of program availability. The services required under the bill are needed to assist parents who are experiencing a most tragic event in their life, receiving news that their unborn child is diagnosed with a life-limiting diagnosis, which is defined as a condition diagnosed before birth that will, with reasonable certainty, result in the death of the unborn child within 3 months after birth. The bill is proactive, as the time of receiving such news is not the time to begin a search for availability of services to assist the family during their time of need. Perinatal hospice services may assist the mother in the hospital or at home with counseling, medical care, specialists, clergy, and social workers who would create a comfortable and supportive environment to assist the mother and family during their crisis. Hospice can provide a compassionate environment and help to protect the mental health of families experiencing such a tragic event. This bill will empower those families with information of resources available to them during their time of need. Currently, there are approximately 300 perinatal hospice programs nationwide and 9 reported to exist in the state of Maryland. And 7 states have passed similar legislation. Based on the statistics of infant mortality in the state, it's estimated that hundreds of Marylanders could be assisted by the requirements of this bill. By publishing this information on their website, the Maryland Department of Health would be the single source for vital information, as they should be. Furthermore, the bill does not require a physician to notify a patient of the availability of hospice services, but only states that they may share such information. There is an amendment which strikes all the language regarding data storage, and the only requirements that remain under the bill, if the amendment is adopted by the committee, are those beginning with subtitle 20, section 20-2001. There's also a second amendment which adjusts the definition of a nurse practitioner at the request of the Board of Nursing. I'm willing to work with any other parties to further amend the bill as necessary. It is supported by agencies such as the March of Dimes, various hospice agencies, as well as parents. And please note that the fiscal note indicates that the Maryland Department of Health can handle the requirements of the bill with existing budgeted resources. I ask for a favorable report, and I'm happy to answer any questions, and thank you for your time.
Sure. Thank you, Delegate Weibel. We will hear from your panel at this time. The first favorable is from Molly Sheehan. Ms. Sheehan, are you available to provide testimony?
Yes. Thank you, Madam Speaker Pro Tem. Thank you to Chair Pendergrass, Vice Chair Pena-Melnick, members of the HGO Committee. For the record, my name is Molly Sheehan, Associate Director for the Maryland Catholic Conference in support of House Bill 1112. You will hear what perinatal hospice does, and you'll hear about the need. I just want to talk about the bill itself. With House Bill 1112, the Maryland Department of Health will publish a list of perinatal hospice services in Maryland, so no family need be left in the dark when seeking this information. The Department of Health will share an information sheet in English and Spanish with doctors, so now physicians will be aware of this option. And if they think it's appropriate, they can refer their patients to these options. The infant mortality rate has continued to increase in our state, especially for Black and Latino infants. We can provide better support for these families. You can read in the written testimony from families who suffered because they lacked knowledge and resources. They've been treated insensitively, they've felt abandoned. Often their providers didn't know about perinatal hospice and had no information to give them. Even in researching this bill, I had great difficulty finding more information about perinatal hospice online. It's simply not fair to ask families in the midst of a crisis, when every moment counts, to struggle to find the services and healthcare they need. And families who have used perinatal hospice share that this information would have helped them when going through a difficult time. This bill ensures no family has to suffer, as some of the moms in the testimonies you may read or that you will hear very shortly. We know from health statistics this bill will help hundreds of Maryland families every year with information that respects the parents' autonomy, because this bill is ultimately about awareness, access, and health equity. And for these reasons, I urge a favorable report on House Bill 1112. I'm grateful for your time and your forbearance. Thank you.
You're welcome. Thank you. The next witness is Meg Eshleman. You're welcome to 2 minutes.
Thank you, Madam Speaker, Pro Team, Madam Chair, Madam Vice Chair, and members of the committee. My name is Meg Eshleman. You have my written testimony, and I would like to share my personal story in order to provide support for Senate Bill 1112. On January 5th, 2010, my husband and I went in to see the first ultrasound for our first baby. We were very excited. That soon changed. Shortly after the ultrasound started, we were told that our child had a neural tube defect. It was quite severe, and that if it was to survive to the end of the pregnancy, then it would likely not live past 1 year. The doctor then provided me with all of my termination options. He said that I could conceive again soon and that I would be able to fulfill my dream of being a parent, and this could just go away. So my husband and I went home and we talked a lot about this. Neither of us had ever expected this to happen. Neither of us had any preconceived notion about what we would do in these circumstances. And we talked and we decided to keep the pregnancy. When I told the doctor that I was to continue the pregnancy, he didn't have many resources to offer. My nurse practitioner didn't call me back. I was left to look for my own support. I felt very little support from my medical professional team, and I had to search and shop around for an OB who would follow my birth plan. So I went to Google and I found some resources linked to perinatal hospice, and I found support, and I found like I had found some resources. But I was pregnant and I was tired and it was difficult. When my daughter was born, she lived long enough for myself and my husband to hold her, and she was baptized. I think that this bill would help families like mine to know that they're not alone and support is out there. If my doctor had known to suggest perinatal hospice from the beginning, my experience would have been a lot easier. For these reasons, I urge a favorable report on Senate Bill 1112.
Thank you for your testimony. Thank you for sharing that information with us. The next witness we have is Mary Paratka. Apologies if I pronounced your name incorrectly, but you have 2 minutes and welcome to our committee.
Thank you to Speaker Pro Tem, to Chair Pendergrass, Vice Chair Pena-Melnick, and all the members of the House Government Operations Committee for the opportunity to speak before you today. My name is Mary Paratka, and I have been a labor and delivery registered nurse for 40 years. And 15 years ago, I started the first perinatal hospice program in Maryland at Howard County General Hospital in Columbia because there was a need. I have been a perinatal bereavement nurse since 1996, walking the journey of healing and remembering and memorializing a life lost too soon to miscarriage, stillbirth, or newborn death. Perinatal hospice is really about life. The goal of all hospice is to enable patients and families to live their best lives as pain-free as possible and for as long as possible. The word perinatal refers to the period of time from about the 20th week of pregnancy, roughly halfway, through the first weeks of a newborn's life. So perinatal hospice takes the best of perinatal care and marries it to the best of hospice ideals. This multidisciplinary approach supports families who receive a life-limiting diagnosis for a child yet to be born or a newly born child. Perinatal hospice is about celebrating life for as long as it is present, creating memories that will last a lifetime, and setting parents on a journey to healing grief and loss, because there is no shortcut through grief. Megan, the mother of one family I walked with, told me we celebrated every day she was with us. Things I would not normally do when pregnant, I did with Rosie. We went skiing, roller skating, we went down water slides and took pictures of our entire family of 5, and we spoke to her. Why is it important for families to be given information about perinatal hospice or perinatal palliative care? Because it expands care options. Please remember that not giving patients options is not giving them a choice. Parents who choose to carry to term deserve supportive information and referral to care. And I thank you and urge a.
Thank you for your time and your testimony. The next witness we have is Heather Silver. You may begin.
Thank you to the committee, Madam Speaker Pro Tem, Chair and Vice Chair. My name is Heather Silver and I'm a social worker and perinatal specialist running a freestanding perinatal hospice in Maryland. So imagine going to a sonogram appointment, excited to get pictures, see and hear your baby's heartbeat, only to hear those heartbreaking words of something is wrong with your baby. Perinatal hospice is a family-centered care for parents who choose to continue a pregnancy with a life-limiting condition. It creates relationship, guides in decision-making, and promotes quality of life for baby and family based around the family's hopes and wishes. It's astounding how many providers are still not aware of what perinatal hospice is, let alone that there are local resources for their patients. These services prove over and over again that they impact mental health in a positive way. Brochures highlighting these resources should be given to physicians because not only are they present when the diagnosis happens, they're chosen by these families and trusted. Families deserve equitable access to information for an informed decision so that families who choose to carry to term have providers that are knowledgeable. Without information, parents run to the internet, which often leads to misinformation. Leaving the office with resources in hand is vital, and the health department is and should be the trusted source. I'm going to talk about two families. The first family was referred at 20 weeks for their unborn daughter, Abigail, with a major heart defect. We helped them process outlined hopes, manage expectations, all while planning for birth and for death. We recorded the baby's heartbeat, did professional photographs, and performed a baptism at birth. Part of perinatal hospice is explaining death to their siblings. That's age appropriate and doing legacy building activities to honor their sibship. Making funeral plans prior to birth allowed the family to fully focus on limited precious time that they had once Abigail was born. The meeting making that happened from pre-planning for the mom donating not only the baby's heart valves, but also her breast milk helped the parents find meaning in the loss. The second family came to a support group after 3 months after losing their son Isaiah, also to a heart defect. After hearing of Abigail's family speak, they stated they were unaware that this kind of care existed. They felt cheated out of the experience to make plans during the pregnancy, to have specialized care for their children, as well as to find joy. They recalled the hospital staff being compassionate and getting a memory box, but their grief was compounded with anger and resentment toward the providers. So this needs to change. This bill will empower parents to make informed decisions. And for this reason, I urge a favorable report on House Bill 1112. Thank you for your time.
Thank you, Ms. Silver. The last favorable witness we have is Ms. Hessler. You may begin. You have 2 minutes.
Good evening, Madam Chair, Vice Chair, and members of the committee. For the record, my name is Teresa Hessler, and I'm here representing March of Dimes in support of House Bill 1112. This important legislation will expand the state's current program by offering information on perinatal hospice programs and resources to families and their babies, providing comprehensive support from the time of diagnosis through the time of birth and death of the baby, as well as through the postpartum period. On average, a neonatal death happens in about 4 per 1,000 babies each year in the United States. According to the latest data from the Department of Health, Maryland's rate of neonatal death is about 6 per 1,000, making our state average higher than the national average. Some of the leading causes of neonatal deaths are low birth weight, abnormalities, sudden infant death syndrome, maternal complications of pregnancy, and infectious diseases. The diagnosis of a lethal fetal anomaly poses significant challenges for obstetricians, pediatricians, and clinicians who often have had little experience or training in how to best care for the baby and the grieving parents. According to one study, the most profound effect these pregnancies can leave on families is often a psychological one. Perinatal hospice offers the parents of babies with life-limiting conditions the chance to love and cherish their newborns for whatever time they have, from a few minutes to days, weeks, or even months. This important program offers a model of care, an extra layer of support that can easily be incorporated into standard pregnancy and birth care. It is for these reasons March of Dimes urges a favorable report on House Bill 1112. Thank you.
Thank you. Thank you for your testimony today. Are there any questions from the committee for our favorable panel? Okay, I don't see any at this time, and I will move to an unfavorable witness, Diana Phillip.
Good evening again, Diana Phillip with NARA Pro-Choice Maryland. I'll be very brief. We honor pregnancy in all its complexity, and we completely understand that everyone needs as many options as possible when faced with a fatal fetal anomaly. However, the legislation is still very troubling to us because it is trying to put in statute this requirement of the Department of Health to list a statement indicating that Perinatal hospice is an innovative, compassionate model of support for a pregnant woman who's informed that her unborn child has a lethal fetal anomaly and who chooses to continue her pregnancy. By mandating legislatively the Department of Health lists the statement, it looks as if the state is saying there's only one option and one response to this particular diagnosis. And I don't think that's where the state wants to go with this. And so we are opposed to this legislation. And we want to remind people that another compassionate option is abortion care. So we are in opposition for this particular legislation. And another reminder that unborn child, when you use that in legislation, it grants personhood, which again is going to prevent individuals with their bodily autonomy and be able to engage in the pregnancy decision-making that's best for them. Thank you.
Thank you. Are there any questions from the committee for our witness? I see Delegate Shaleka. You may ask your question.
Thank you very much. So Diana, you don't find any room for the State Department of Health to provide this information for parents who don't know that this exists?
I think it doesn't need to be legislated, Delegate. I think that this is a conversation to have with the Department of Health, but not necessarily statutorily required, as if this is the only option. And that we don't want the state to be in trouble saying this is the only option by having only.
Well, what if we said that's a choice? What if the language was more permissive and said it was a choice? Because parents truly, I had a full-term stillborn child. I didn't know any of this existed. This would have been so therapeutic for me and my family. I mean, families just don't know this is available. And information and transparency, we have a patient's bill of rights. We have hospitals and physicians share information with patients all the time. You don't think this is a great service that is offered to parents in this really difficult time?
I would also like to have patients have the information about later abortion, which is compassionate care. And we hear from patients where it's taken a long time for them to find that expert healthcare in order to terminate the pregnancy, which is in the best interest of their family and their fertility. So again, I don't think that the state should be mandated on only one option. And I think that the legislators that put together this bill, if they could have a conversation with the Department of Health, perhaps they could come up with a better solution.
Yeah, I guess we're going to disagree now. Our one final question, Madam Speaker Pro Tem. So is abortion available all for the third trimester here in Maryland?
That's
yes, to you.
Yeah, later abortion is, we do have a provider in the state of Maryland that offers later abortion, yes.
Up to 40 weeks.
Up to whatever the provider and the decision that's made with that particular patient. I don't believe it's up to 40 weeks for that particular provider.
Thank you.
Okay, thank you. Delegate Krebs, you're next.
Thank you. And I should have asked this question to Mary Peruka, who does this, but I'll ask Diana, since you're there. I've been in hospice board for 10 years in Carroll County. And I can tell you, until I saw this bill, I never really knew or thought about perinatal hospice services. And now that I hear about it, I'm like, wow, how did I not know this? And what an opportunity to offer it. And I can tell you that there's no one that I know that does not know abortion services are available very easily. So I think we can agree to that. So given that be such a terrible thing to make sure that people know this option is available, because I feel really embarrassed that I never knew it. And I really feel like we should let people know that make that choice. And again, I think people know what the other options are and have easy accessibility to it. Why would that be problematic?
I still think that the bill sponsor should have a conversation with the Department of Health about how to do that.
Okay, thank you.
Okay, thank you, Delegate. The next we'll have Delegate Johnson.
Thank you, Madam Chair. And this question is also for Diana. Is that one part of the bill the only thing you have an issue with, just the part that requires the state to make that statement?
The language about unborn child the way that we analyzed the bill, it seemed at first that the materials would have to be generated by the state to give to the provider to offer to the patient, but listening to the Catholic Conference, that doesn't appear to be the intent. So again, I still think that this is not something that needs to be statutorily required, but can be something worked out with the Department of Health.
All right, thank you. Thank you, Madam Chair.
You're welcome. Delegate Rosenberg.
Question for the witness. Does Maryland law limit the circumstances under which an abortion can be performed after the fetus is viable?
It is the viability of the fetus is if there's up to the point where that determination is made. If the fetus is no longer viable, then abortion care is offered in our state. It's legal.
But under limited circumstances?
Yes.
Thank you.
Okay. Are there any additional questions from the committee? I just don't want to overlook anyone. Okay. I don't see any. This concludes the bill hearing for our House Bill 1112. And it also concludes our hearings for today in the Health and Government Operations Committee. Thank you all for being here today and have a good evening.